Hello, my name is Grace Manelli, and I am doing my presentation on liberation bundles for ventilators in the hospital setting. So basically, the health question that I developed is in patients who are on ventilator support in the ICU. Would implementing a standardized, spontaneous awakening trial, breathing trial, also called a liberation bundle, decrease the amount of time that the patient spends intubated, therefore decreasing a lot of the complications that patients tend to get while they're intubated, such as healthcare-associated pneumonia or HAP, as well as other complications such as increased length of stay in the ICU, increased days ventilated, and the likelihood of them leaving the hospital and leaving the ICU, as well as their mortality also plays a part in that. So that is my question. The two articles that I found, one you'll hear me reference as Anderson. The other one you'll hear me reference as Nita. The Anderson trial is a trial in a hospital in Pennsylvania where they implemented a so-called liberation bundle, where they implemented a certain number of parameters that patients could meet then to expedite getting extubated, because they found that without this liberation bundle, patients were spending more time intubated for reasons such as being overly sedated, poor communication between the doctors and the nurses, and other factors that this liberation bundle then took out. It was very successful. It's actually now implemented at the University of Pennsylvania Hospital, and they're using this liberation bundle, which is how this applies to everyday hospital life. I currently work in the cardiovascular ICU at Nebraska Medicine here in Omaha, Nebraska, and I have been implementing a liberation bundle in my area, and we've seen a massive increase in patients getting extubated quicker because the nurse doesn't have to mess around with if the doctor's orders are in, the bundle is already in, and we already know what to do to get these patients extubated. The Anderson article, the patients were 28% more likely to be extubated, 31% more likely to be discharged from the ICU, and the median duration of mechanical ventilation was 2.2 days shorter, and the median ICU length was 2.65 days shorter compared with everything else. This article also had a lot of research that was statistically significant, which you can see from my p-values and the logistic regression, which is the method that they used. Every single p-value for the Anderson articles was significant, especially the likelihood to be discharged from the ICU, which was one of the big reasons to why I chose this article. The Nita article focuses more on after extubation. They have their basic liberation protocol for getting patients extubated, and then they deal a lot with after extubation, different methods that they can use to keep patients extubated, because patients who are re-intubated are actually 5 times more likely to die in the ICU if patients get extubated and then have to be re-intubated. So theirs focuses on an extubation checklist, which includes like the evaluation of respiratory status and assessing the need for things like CPAP, BiPAP, and other oxygen after they are extubated. They're two very different ideas, very different methods, but all come down to the fact that they want to get these patients extubated safely. We already kind of talked about the importance of it in my field and getting these patients extubated. It's very important being on the ventilator can cause a lot of harm, including infection, increased length of stay, all of those things that we've already talked about. Now I'm going to dive a little bit into the statistics of it all, as well as the methods that they used. So the method that the Anderson article used was a proof of concept study that they used to prove basically that this liberation bundle and being extubated would work as a study. And then their main study was the before and after study. So they had 457 ICU patients, 221 were tested pre the liberation bundle being implemented, 236 were post-intervention. They used logistic regression, which has a lot of good strengths to it. It's very accurate, easily interpreted data because it was a large sample size. That also worked with logistic regression. And based on those, the findings were the likelihood of extubation had a p-value of 0.042, likelihood to be discharged from the ICU had a p-value of 0.027, median days of mechanical ventilation 0.042, and median days of ICU length of stay was 0.04, which were all statistically significant, saying that this liberation bundle did decrease all of those things. And it was very significant, which is probably why it was implemented at a hospital. The NEDA study was an observational study, so they just basically watched patients as they implemented this bundle. They had 248 ICU patients, which is also a good sample size. They also used logistic regression. Their two main tests were the median days of ICU length of stay and mortality, because they test a lot of, okay, if you're being re-intubated, how likely are you to die in the ICU? Neither of theirs were statistically significant, 0.058 and 0.057, but the actual data itself did show some improvement in the patients. It being an observational study, them implementing it and not having patients who they did not implement the bundle on, I think limits their study a lot. It could also be why the p-values were not statistically significant for these studies, but I wanted one that was not just a liberation bundle that was implemented on the patients, but some that dealt with post-extubation as well. These studies, their strengths for sure, they had clear variables, they knew what they were looking for, the large sample sizes helped. They defined the parameters, they had their goals of what they were looking for. The logistic regression we already talked about is easily interpreted data, has good accuracy. Limitations, all of these articles were only done on a single hospital. The Anderson article did not take in illness severity as well. As we talked about, the observational study is a limitation, and limitations for logistic regression are as it assumes linearity and it's not good for complex relationships, which this could be. This topic needs a lot more information added to it. The Anderson one implemented a system of alerting nurses. So how you alert the nurses is a good one. The other research that needs to keep being done is exactly what goes into the liberation bundle in regards to drugs, the ventilator settings, and everything like that. They need to narrow down exactly what they want to put in these liberation bundles before they really implement them throughout the nation in more than one hospital. What worked for the University of Pennsylvania could not work in other hospitals. So I think that would be other good research topics. I hope that you guys got a little bit more information about this and extubating in the ICU with liberation bundles. Thank you for your time.